I'll give it another minute before we begin. Thank you everyone for your patience. All right, we will begin. It's a minute after 9 a.m. Good morning, everyone, and thank you for joining today's public workshop reviewing MSM Chapter 4000 updates. Can everyone see the slide and hear me? A thumbs up. All right, thank you. My name is Christina Cobeo, and I am a Social Service Program Specialist 2 in the Behavioral Health Benefits Coverage Unit with Nevada Medicaid. I oversee the 1915I Home and Community-Based Services State Plan option, specifically for intensive in-home support services and crisis stabilization services. The purpose of these updates is to ensure alignment with state plan, improve clarity, and standardized terminology across all documentation. These changes impact eligibility criteria, service definitions, provider requirements, and procedural guidance. Feel free to jot down questions. We'll have time for discussion at the end of this presentation. As a friendly reminder, this workshop is being recorded, and the slide decks and policy drafts are posted on Medicaid's Public Notices webpage. Let's take a look at today's agenda. First, we'll start with the introduction and purpose of updates. To give a brief introduction into the 1959 services, in March 2025, Nevada Medicaid received clarification from CMS through RAI Communications that certain services currently approved under the 1915I benefit include components that must be provided under the EPSDT benefit for Medicaid eligible children under age 21. Federal Law Section 1902A and Section 1905R of the Social Security Act requires the state to ensure their Medicaid state plan reflect all necessary information for CMS approval in compliance with EPSDT requirements. CMS requested a timeline for Nevada's transition to providing these services pursuant to EPSDT, prompting the policy unit to update the policy to align with federal requirements. Nevada Medicaid 1915I was contingently approved on June 30th, 2025, with the condition that CSS be redefined and a clear justification provided for the inclusion of family stabilization services for specialized foster children. Through extensive revisions and internal collaboration, we have successfully demonstrated the habilitative intent of these services. On January 15, 2026, a 15-day call was conducted to finalize proposed edits to state plan. During this discussion, CMS acknowledged the critical need for youth in foster care to develop coping skills that were previously unavailable to them. The redefined 1915I HCBS specialized foster care and home support services and family stabilization services were presented during the public workshop held on November 20th, 2025. Following these updates to state plan, MSM Chapter 4000 was aligned with revised language and service definitions to ensure the continuation of family services, stabilization services, and incorporate additional technical adjustments, which we will review shortly. I'd also like to recognize the specialized foster care providers who partnered with the Behavioral Health Unit policy team to address audit findings identified by our surveillance unit. These collaborative efforts resulted in clarifications within MSN 4000, including guidance for eligible providers to document credentials where required, such as family stabilization services, which begin at the QMHA level. Licensed foster parents continue to provide in-home support services without coaching, helping at-risk youth build essential coping and rehabilitative skills. Guided by licensed professionals who develop individualized treatment plans and reinforced through weekly family stabilization services delivered by dedicated providers, we are making meaningful strides towards our mission, putting kids first. Next, we'll review terminology changes. Consistency is key, so we'll go over updated terms to ensure policy is aligned with state plan. Then we'll move into eligibility and assessment updates. We'll discuss what's changed in eligibility criteria and how assessments will be conducted moving forward. After that, we'll cover care coordination. This section focuses on how updates impact coordination between providers and services. We'll also review provider requirements. Here we'll outline new or clarified expectations for providers delivering these services. Following that, we'll look at service updates. This includes changes to service definitions and standards. Next, we'll talk about documentation and monitoring. We'll highlight what's new in documentation practices and monitoring procedures. Then we'll move into billing and administrative updates. This section will explain changes to billing processes and administrative guidance. Finally, we'll wrap up with conclusions and next steps. We'll summarize key takeaways and outlines what happens after today's session. At the end, we'll open the floor for Q&A and public comment to ensure clarity and gather final thoughts from specialized foster care providers. Give me a moment while I share the PDF of the MSN. Beginning on page 1 of section 4000, the introduction begins with the name change from references to DHCFP have been updated to NVHA, and mentions of Nevada Medicaid have been added through the policy. For efficiency, I will refer to this change as Nevada Medicaid moving forward, as the updated name appears consistently through the document. On page 4, section 4003.1, needs-based eligibility criteria, Medicaid removed children/youth and replaced it with recipients to align with state plan. Section 4003.1A and subsections were added. Grammar, punctuation updates added in subsection introducing ETSI and CASI tools. Medicaid added the locus assessment tool and clarified level of risk score aligned with the state plan and the PT 86 eligibility checklist. On page 5, section 4003.1 B and C, we added language describing care coordinators' use of biosocial assessment support tools. An impaired functioning and service intensity section was added as well as the removal of a duplicative section and clarified other community alternatives to align with the state plan. On page 6, Medicaid added a clear provider framework to define who can deliver services to include licensed professionals, QMHAs, and QBA roles, and reference attachment 3.1-A. On page 6, section, we did review that, excuse me. On page 7, section 4003.C, covered services, we removed crisis stabilization services and renamed them to family stabilization services. On the bottom of page 7, section 4003.3, a new billing section was included in policy. To Beginning of page 8, there is clarification of service limitations with in-home support services with and without coaching was added. Page 9, section 4003.4F1C, provider responsibilities. Clarified the assessments are provided by licensed professionals, certified professionals, or QMHPs functioning within their scope of practice. Screenings are provided by licensed professionals, certified professionals, QMHPs, or designated QMHAs functioning within their scope of practice. On page 11, 4003.4 on number 6, we removed if credentialed, added eligible providers who delivered the service to include the provider performing the service is licensed or certified, then the credentials must be included. On number 8, we included objective goals, POC/PCSP, or lack of progress. On page 12, we added subsection D, monthly monitoring must include a review sample of progress notes for all structured activities as required. If any deficiencies are identified in either the delivery of services or the documentation of those services, corrective education must be provided to the staff member by the specialized foster care agency. All corrective actions and related training must be documented in the employee's personnel file. Family Stabilization Services. We renamed Crisis Stabilization Services to Family Stabilization Services, and we've redefined FSS to align with state plan. Section 4003.6, Family Stabilization Services reads as follows. Family stabilization services are short-term, outcome-oriented, and high-intensity behavioral services. FSS are identified on the Person-Centered Service Plan, PCSP, which outlines goals and services for recipients learning new skills following experiences in traumatic environments. The recipient's home of origin lacked the provision of effective coping skills, leaving them without the necessary skills to manage their emotions and distressing experiences. FSS is focused on developing effective behavioral methods prior to, during, and following a crisis. These services are delivered in individual one-on-one sessions with the individual foster family by a trained qualified mental health associate, QMHA, licensed professional, or qualified mental health professional, QMHP. Services can be rendered available in the recipient's home and community and designed to achieve family stabilization. The intent of the service is to develop effective behavioral methods that can be sustained long-term. Family Stabilization Services, FSS, may be furnished to children in foster care, living arrangements, and the service is necessary to meet the identified needs of the child. Pursuant to 42 CFR Subpart D, 1959 funds are not available to pay for maintenance, including room and board, and supervision of children who are under the state's custody, regardless of whether the child is eligible for funding under Title 4-E of the Act. The state assures that the claim for family financial participation, FFP, for FSS does not include costs that are properly charged as Title 4-E administrative expenses. To ensure compliance with federal requirements, the state affirms that 1959 services do not include funds available under the Title 4-E of the Social Security Act. Page 16, we clarified division to mean Division of Child and Family Services. On page 17, we added a note that QBAs may not provide FSS services. We added language for eligible providers performing in-home support services, as well as adding their credentials to documentation if they have credentials. On page 19, we added subsection 13 to say intensive in-home support services without coaching may not be billed at the same time as family stabilization services. Lastly, we added section 4000 to include that additional units of FSS may be authorized by Nevada Health Authority or designee post-review. In conclusion, these updates are designed to improve consistency, clarity, and service delivery standards. Thank you for your attention and commitment to providing quality services. If you have additional questions after today's session, please reach out using the contact information provided on the last slide. Your feedback is essential as we continue to refine and improve our processes. Excuse me a moment while it transitions to another slide. The effective date for these proposed changes is April 29th, 2026. There is no anticipated fiscal impact. This concludes my presentation on proposed changes to the MSM 4000 updates. Now we are open for public comments. Thank you. Here is my contact information. Please feel free to submit further comments or questions to our behavioral health inbox. Thank you.
Thank you, Christina.
It looks like we don't have any comments for today, so I'll give you back your day. Thank you, everybody, for coming and participating. I appreciate you.